community-based participatory research, which involves community stakeholders in the conduct, design, and implementation, as well as dissemination of that research. So let me just share a few ideas about CBPR, community-based participatory research. This was really championed by the Robert Johnson Foundation. I was part of the Clinical Scholars Program, where they had a third-generation clinical scholars program that was focused just on CBPR work, right? And so I was at the University of Michigan. As you can see, at that time, I did not have as much white hair in my beard. But there were 9 principles championed by Barbara Israel, one of the foremost thinkers in this domain, around CBPR work. And I'm going to go through each one of them to give you a sense of what this is about. So the idea was that communities are, the first principle is about community as a unit identity. That patient healthcare behaviors are situated within the context of a community. You must address community values and norms when you think about changing patient behaviors. The second was about building strengths and resources within the community. If you want people to maintain their health, you must address, right, in an asset-based way, what's occurring in the community that they live in. You want to have a principle of facilitating collaborative and equitable partnerships in all phases of research. So if you're going to do community-partnered and participatory research, you want to empower those communities in both the design, implementation, as I said, the dissemination of that work as well. You want to promote co-learning and capacity building. So we might, as researchers, know what to do, but we don't know how that will be actuated and implemented in the community. So we want to involve them in thinking about how to implement work. You want to integrate and achieve balance between research and action. And this really means services. Right? So when you do work in communities, they're interested in health services, not health research. So you want to be thinking about how this program of research leads to services that are offered to the community. The sixth being emphasizing relevance of public health outcomes and ecological perspectives, again, drawn from community perspectives here, the lived experience of individuals in those communities. The seventh being involving systems development through a cyclical and iterative process. And then the eighth and ninth really talking about dissemination and long-term commitment processes. Again, the idea is that we shouldn't be going to communities, doing research and leaving, but rather we should be going to communities and helping them develop the processes and structures to continue that sustainable benefit in their settings. So the positive benefits of this CBPR approach was that health equity would be advanced, right? That sustainability would be enhanced, trust would be built within communities, actionable evidence generated, not just evidence that works in an RCT that's controlled, and that societal health would be advantaged. If you fast forward a few years, right, with the onset of the ACA, we had this other research institute that was brought about, the Patient-Centered Outcomes Research Institute, PCORI, that was focused on improving CBPR approaches, right? So for them, the idea was that we're going to add a few different things to upon CBPR work. First, we want to focus on patients and caregivers. Caregivers of patients were often left out in research protocols, right? Yet they are the ones who are able to help the patients get healthy, but also have their own health issues when they're caring for individuals. For example, in end-of-life care, you know that the caregivers are ones oftentimes that have difficulties with their own health when they're caring for individuals who are dying. They also added this idea that, you know, to affect healthcare system change, you need to bring in other stakeholders that are not present in communities. For example, pharma or health systems and payers. They all affect the way in which programs are developed, how research is conducted, but often they're left out and marginalized. You want to bring them into the process. And then they wanted to add this idea about situating roles with capacity and with funding, right? That you might not have everybody in a project in your community-based work be a full collaborator. They might be consultants or informants. And you need to be able to remunerate them at the appropriate level. So PCOR obviously had their own principles and engagement rubric. There are 4 main principles that they have relating to reciprocity, equitable partnerships, co-learning, and transparency, honesty, and trust. I will let you read them if you like. They really echo the same ideas that the community-based research had. But what's important here was that they were very deliberate in laying out a process by which you think about collaboration across the 3 phases of a study, right? Planning, conducting, and disseminating. So if you were to apply for PCORI funds, I've been lucky to have been able to get some, they want you to delineate specifically how you're involving your stakeholders in each of these 3 phases. So boiling this all down into my view of what all this means really, or what's common, is the idea of joint ownership in research, right? That you should think about research in partnership with communities such that the health priorities and needs of those communities are met. That's where the idea gets generated. That's what the focus should be, not just on what we need to advance our careers, right? The research design should be collaboratively developed, right? So you might think about an RCT, but I'll tell you as a community-based researcher, oftentimes I can't do RCTs in community settings because they're not willing to have a sham intervention. So you must think about, again, not what's just very important for our research careers, but what is important for the community. And then in project dissemination, we often focus on papers and publications, right? But that's not what's important to communities. So you think about how they are advantaged through the work that you're doing. The other sort of idea here is capacity building within communities, right? The knowledge, tools, and programs that we develop should be valuable to the community itself, right? They should be empowered to create programs that benefit their health, right? And that should be a principal focus of our research work. And lastly, to address this gap between knowledge and implementation, right, that we shouldn't be focusing just on research, but on services, as already mentioned, healthcare services, and that our data should drive policy changes for health and healthcare behaviors. So with that said, again, I just want you to note that this is a PCORI rubric, right, that we should be thinking about not just informing communities about their health, but actually going towards empowerment to be activating them around their own health. So how does this relate to our field, right? So we know over the last several years we've had increased focus on social emergency medicine, right? The fact is that we recognize as a specialty that we're not just acute care specialists, but rather we're also population health interventionalists. Right? So we should be focusing on all those factors that inform the health and influence the health of our patients when they come into our doors. Right? So we want to address the fuller determinants of health, the social, economic, and structural determinants as well, and that we should be attending to the barriers to health activation for our patients, right? The cultural, linguistic, and religious barriers for them maintaining their health. So this has been a more focus of our specialty, and again, this lends itself to community-based and engaged research dynamics. The last piece is that as public health interventionalists, and you might have seen this, right? Health in all policies, we should recognize that health is produced where we live, work, worship, and play. Right? And that our research should think about that sustainability in those different domains of people's lives. So you might see this already in your EPIC sort of portals, where we have these social determinants of health wheels or frameworks that are at the intake for our patients, right? And that we have developed already over the last 20 or so years, a great screening, brief intervention, and referral to treatment programs for certain aspects of that. You might not have it for all of those domains, but we are now focusing on addressing the social determinants of health of our patients. So for me, and I'll end here, right, that my work has now moved outside of the ER to actually community settings, right? So this is a project that I led through PCORI funding on actually identifying the health priorities for the Muslim community, right? So we did a Delphi Method, a national conference on this, and based on their health priorities, it led to an RCT that was conducted on organ donation and end-of-life care, right? Again, based on the community priorities, and then in a community participatory way, we developed a RCT related to that. And in the end, about community capacity building, after that project, then the community partners themselves wanted to get more capacity building about how to conduct their own research. So another project led to a toolkit to empower them with PCOR tools. So my point, and I'll end with this, is that we should be thinking about a full spectrum research that is embedded within communities, right? So for, by, and with them. Thank you. I'll turn it over to Kaylin.
Thank you so much. And I'm a little shorter, so I'm going to just bend this down here a little bit. So thank you for that introduction. Good afternoon. My name is Kaylin Folkley, and I'm a Population Health Research Fellow and soon-to-be Addiction Medicine Fellow at the University of Washington. Since becoming a physician, I've witnessed a tremendous change in my emergency department's culture around addiction and the type of care provided to patients with substance use disorders. And I'm so grateful for the opportunity to assist with this work. However, I did notice that the voices of those who use drugs were notably absent in the design and implementation of this programming. Motivated by this, I became involved in the formation of the Research with Expert Advisors on Drug Use, or what we lovingly named REDO. So first we'll discuss REDO's funding and formation. Although there has long been a movement locally to build a coalition of people who use drugs, this most recent push began 2 years ago when the University of Washington Addictions, Drug, and Alcohol Institute, or ADAI, hosted folks from the BC CoLab out of the University of Victoria. The BC CoLab is funded by the Canadian government to create a collaborative community laboratory on substance use and harm reduction. They've done this by developing a network of people with lived experience and centering them in a group supported by research scientists and community organizations. The BC CoLab has been able to recruit people with lived experience from several already established drug user unions, like those listed here. In this way, the BC CoLab has facilitated the active participation of folks with lived experience in every step of the research and advocacy process. They've created guidelines to better include people who use drugs in policymaking, clinical standards for the treatment of people who use drugs in hospitals, and published peer-reviewed studies on harm reduction. Inspired by this incredible co-design work of the BC CoLab, among many others, Public Health Seattle and King County applied for funding through the CDC and the National Association of County and City Health Officials to begin this work locally. With big dreams and just a little bit of money, we got to work building Redo in the new year. With the assistance of Public Health Seattle and King County, we recruited academic researchers from across the University of Washington's campus, including the Addictions, Drug, and Alcohol Institute, like I mentioned before, ADAI, the School of Public Health, the School of Nursing, the Harm Reduction Research and Treatment Center, and of course, the Department of Emergency Medicine. The Public Defender Association, or PDA, was then identified to lead the charge. The PDA is a local nonprofit organization which advocates for criminal legal system reform and develops alternatives that shift from a punishment paradigm to a system that supports individual and community health. They have several associated entities that assist them in this mission, including the Law Enforcement Assisted Diversion, or LEAD program, which is a post-arrest, pre-booking diversion program that redirects folks involved in drug possession or sex work to intensive case management instead of jail and prosecution, and they'll come up a little bit later. Leadership from the Public Defender Association and Public Health Seattle and King County have facilitated listening sessions and surveys at organizations throughout our community. And over the last year, have fostered Redo's early formation with the hopes that the voices of people with lived experience will be amplified. Depending on their interest and time, folks will have opportunities to engage in lighter ways, like listening sessions, or in stronger ways, like formally participating as co-investigators in research. So next we'll discuss how we hope to implement co-design methods with people with lived and living experience. In more traditional research studies, experts or people with lived experience would be passive participants in things like interviews or tested on as subjects, while others more participatory projects may have experts advise the research process. However, co-design research ensures that experts are not just advisors, but active participants in this work. And this is the work we aspire to do with Redo. So, we received intramural funding through the University of Washington to hire 5 co-researchers with diverse lived experiences. Our co-researchers work 5 hours per week and are involved in every step of the research process. They are paid $25 per hour plus $50 per week for food and technology support. We engaged in bidirectional training, during which experts educated the research team on their lived experience, effective outreach strategies, experiences with past data collection, and how to extend invitations for research in an ethical way. While the research team shared knowledge with the experts about aspects of research design, data collection, and analysis. We've had sessions on things like sampling strategies, where we map all those involved in an overdose response, and reflections on the assets and goals of each team member. We're using a collaborative and iterative framework that we've been calling the Discover, Design, Build, and Test, or DDPT, which we have adapted from the UW Alacrity Center, with the purpose to discover community needs, redesign solutions with the folks most affected, and implement and pilot and evaluate feasibility together as one cohesive team. During the Discover phase, the academic researchers and co-investigators will do some data gathering through team meetings, interviews, and community pop-ups. During the Design and Build phases, we will facilitate design workshops with experts. And then we will test these co-design interventions together. Okay, so that was a lot to get through. And now I just wanted to focus on some things and what's been happening in Washington State that's really allowed us to use this method in action. So 2 years ago, the Washington State Supreme Court struck down the statute that made possession of controlled substances a Class C felony, removing any state criminal penalties for possession. So essentially, drugs became legalized. Then the Washington State Legislature fired back with Senate Bill 5476, which mandated a whole lot of things. Instead of completely decriminalizing drug possession, Washington State Senate Bill 5476 deems drug possession a misdemeanor, but requires law enforcement to divert those caught with drug possession to treatment and services in lieu of booking. The bill outlines that law enforcement can divert folks to a variety of places listed here, including the emergency department. But focuses on the development of the Recovery Navigator program, which will exist in every region of the state. It will be modeled on the Law Enforcement Assisted Diversion, or LEAD program. Remember, that's under the purview of REDU's community partner, the Public Defender Association. Similar to other LEAD programs across the country, the Recovery Navigator program will provide outreach, intake, assessment, warm handoffs to services, intensive case management, recovery coaching, stabilization housing, and legal system coordination. However, notably, it does not currently offer any clinical interventions. This bill also mandates that basic training for all new police recruits include a focus on substance use disorders and law enforcement interaction with people who use drugs. It will be developed in conjunction with the Behavioral Health Institute at Harborview, our county hospital. Additionally, the Washington State Healthcare Authority must hire someone to support ED-initiated buprenorphine programs throughout the state. Our research launch is well-timed to address a couple of these recent legislative changes. We have decided to focus on two aspects of Senate Bill 5476, which mandated training on law enforcement interaction with people who use drugs and diversion in lieu of jail booking for drug possession. Although first responders have historically responded in cases of emergency, like overdose, they have not typically focused on evidence-based treatment and interventions to prevent overdose death and increase access to care for people who use drugs. So this led us to our two proposed pilot projects. Piloting a contact and training intervention for first responders to reduce overdose stigma, and adapting evidence-based interventions from clinical medicine to the first responder system. In this first project, we plan to inform a new state-mandated curriculum for all new law enforcement recruits around opioid overdose into the Crisis Intervention Team, or CIT training, which traditionally focuses on behavioral health crises. Senate Bill 5476 identified the UW Addictions, Drug, and Alcohol Institute, or ADAI, and the Behavioral Health Institute that I mentioned earlier to create a curriculum that addresses these 9 state-mandated domains. We will use co-design methods with ADAI, the Behavioral Health Institute, and REDU to implement this curriculum. We are currently doing this by first discovering the needs of first responders and their perceptions of people who use drugs through interviews. Then adapting the traditional training to include content on opioids delivered by people who use drugs through community pop-ups and design workshops. And finally, we plan to test the adapted intervention on first responders' perceptions of people who use drugs. In the second project, we will adapt evidence-based interventions like HIV and hepatitis C testing, buprenorphine treatment, and take-home naloxone distribution to the first responder system. This work will inform our county's emergency medical service overdose prevention strategic plan, leveraging the newly formed 5476 Recovery Navigator system and expanding the scope of existing local programs like those listed here. We will do this by first adapting these interventions to meet the needs of people who use drugs through interviews, then assessing the barriers and facilitators to adoption by first responders through interviews, and then finally creating an implementation toolkit through design workshops. So here we are in the spring of 2022, finishing up interviews with our co-investigators and beginning analysis, and we plan to do the design workshops this fall. Now I'm going to hand it over to my colleagues from LA.
Hi, everyone. Last but not least, I'm Natasha Thomas, and this is Kabir Yadav, and we're both from Harbor UCLA Medical Center in Los Angeles. Kabir is our Vice Chair of Academic Affairs, and I'm the Director of our hospital's Trauma Recovery Center. And today we're going to be talking about two of our social medicine initiatives that we have at Harbor and how community engagement played a large role in the development and growth of both of these programs. So the first is our hospital-based violence intervention program, and the second is our trauma recovery center. So first, here's a conceptual model on how community engagement, when used impactfully, can drive us towards health equity and healthcare system transformation. So at the center of this model is the community engagement piece and the core principles that should be followed in order to create a sustainable program. And the four propellers are indicators of impact and show us what we can move towards if we use community engagement impactfully. And so we can develop strengthened partnerships, expanded knowledge, improved programs and policies, and thriving communities. But to get to this point, it requires a solid foundation and understanding of the drivers of health, the drivers of change in health, and the sociopolitical, economic, and racial context of the problem that we're trying to address. So I'm going to talk about how at Harbor we were able to partner with a nonprofit organization called Southern California Crossroads to develop our hospital-based violence intervention program. But first, I'd like to provide a little bit of context of the problem that we were trying to address. So this is a map of Los Angeles County divided up into various service planning areas, or SPAs, that help us from a public health planning standpoint. So Harbor is located in SPA 8, and the majority of our patients come from SPAs 8 and 6. SPA 8 is the South Bay, and then SPA 6 is South Los Angeles. So this is a breakdown, a racial and ethnic breakdown of the two SPAs that we primarily serve. On the top left is SPA 8, and on the bottom right is SPA 6. So as you can see, a vast majority of our patients identify as Black and Latinx. And then here are some facts about social determinants of health that affect our patients. So over 9,000 individuals are unhoused. 37% classifies food insecure. Close to half of the individuals that live in SPA 6 perceive their neighborhoods as being unsafe, and 38% are uninsured. And this is a breakdown of the leading causes of premature death, both in LA County and then within our individual SPAs. So as you can see, for SPA 8, homicide is the second leading cause of premature death, and that kind of mirrors what the data for LA County in general. But drug overdose is the fourth leading cause of death, which differs from the rest of the county. And in SPA 6, homicide is actually the leading cause of premature death. And this graph shows us that the homicide rates in both SPAs 8 and 6 are much higher than the rest of the county. So then we looked at the data of our trauma patients at Harbor. So in 2017, we looked at the racial and ethnic breakdown of our violently injured patients that sought care at Harbor, and we found that Black and Latinx patients were disproportionately affected. And then we looked at the mechanism of trauma for the patients that came into our trauma bay, and found that violent injuries made up about 25% of our traumas that year. So realizing that this was our context, we realized that there was a need for us to go beyond the standard of trauma care and work to address some of the drivers of health and health disparities that were affecting our patient population. So, and that's how our hospital-based violence intervention program was created. So it started in 2017, and initially it was a multidisciplinary initiative with our trauma department, our Department of Emergency Medicine, and our social work department. But the key component to this partnership was Southern California Crossroads. So Crossroads, they are a nonprofit organization that started in 2005 to address the high rates of interpersonal violence that we have in LA County, and specifically with the focus on gang reduction and youth development. So going back to these core principles of community engagement, these are all principles that we try to embrace when building this partnership with Crossroads, but a key point of it was the equitable financing. So although it started as an unfunded initiative, in 2018 we were able to apply for funding from a foundation that supports community building, and we gave the majority of that funding to Crossroads, and they used that to hire case managers that could then provide services at Harbor. And we kept a small amount of that funding to hire a liaison or program coordinator to interface with Crossroads and the hospital. So a key principle of our hospital-based violence intervention program is that engagement starts at the bay, but recovery continues upon discharge. So our case managers are people from the community, they understand the needs of the community, and they have lived experience. They provide bedside engagement in the trauma bay and in inpatient, and provide longitudinal case management upon discharge, with services such as vocational training, youth development, tattoo removal, and we're constantly checking in with our case managers to ensure that we are addressing the needs of our community. And we also interface with various community partners to ensure that we are providing that longitudinal social support. And in addressing the needs of our community, we realized that we needed to go beyond just that hospital-based violence intervention program, and that's how our Trauma Recovery Center was started. So Kabir will talk more about that.
So, one of the things that that really came out from the initial work with HVIP was the idea that there was definitely an unmet need in terms of mental health, and there was a stigma there. There was clearly a need to address PTSD, and to address it, we needed to come from a place of trust, and we realized that the medical center is not necessarily the place that people trust, which was something that we needed to take a different lens to approach. So this brought us to really, with, frankly, partners that were very familiar with trauma-informed care, to really embrace the idea that there is much to be done, and taking the lens of trauma-informed care will help us get there. And so what we did was, again, went back to that engine of community engagement to drive all those improvements in societal health. And we focused on trying to widen our lens to improve the services that we would be providing to our community and to help our community thrive. And to get there, we're focusing on the issue of gaps in mental health services. So number one, the HVIP was looking at interpersonal violence, right? And typically that was gang involved violence. And there was clearly more there, but to make it more broad-based, to make it more accessible, to come from a place that people would trust, we had to move it outside of the hospital. And we were going to leverage some services that were around and available. So one of them is the California Victims Compensation Board that was funded through a state proposition, provides restitution funds for victims of violence. But they saw that there was an opportunity to provide more services through the funding that they had, and their opportunity there was to create trauma recovery centers. So victim services offices are trying to get to the victims of violence. They're trying to reach out to community members that either have mental health issues or immigrant or refugee groups, non-English speaking, and people in poverty. These are all patients that come to the emergency department, but not necessarily the right setting for them to engage in this care. And we also needed to address the very diverse community that we had, and how to meet their needs in a culturally appropriate way. So how did we get there? So we had already this experience with working with the CBO. So we knew that was an opportunity to build out more services. So rather than just consult with one or two CBOs, we started casting a much wider net to look for where trauma-informed care and services could be provided. So that included CBOs that were involved in intimate partner violence, CBOs involved in trafficking, CBOs involved in obviously mental health needs as well. And the goal here was to provide mutual referral pathways, that they could bring clients to the Trauma Recovery Center, and we could refer clients to them as well. And one of the opportunities to really understand what the community need was to look at the South Bay Community Council. This was a community academic partnership at our research institution co-located at the Harvard-UCLA campus, which was founded by one of the civil rights leaders in Los Angeles, Miss Loretta Jones. And this was coming from a place of trust and mutual understanding that had been around for several years. And what it allowed us to do was then to hold a community symposium where multiple groups with deep ties into the community brought their community to the symposium and to talk to us about what they needed, what they thought trauma recovery looked like. what they thought the outcomes are that we should be looking at to measure success. For those of you that have perhaps been somewhat familiar with violence intervention programs, there's this idea of recidivism. Like the only outcome that matters is whether you're back in the trauma bay with another violent injury, which frankly can be quite offensive. The needs are much broader than that. The outcomes are much more, need to be much more patient-centered. And not surprisingly, we heard that from the community as well. We used a mixed methods process to, one, get some quick answers so we could start the community engagement piece for this next phase, but also a more deeper content analysis to really make sure we were listening to every group and understanding all of their needs. So like I mentioned, California Victim Compensation Board was a driver of funding for this initiative, and what they were leveraging was the existing work already done at UC San Francisco with the Trauma Recovery Center manual. So what did we do? We were centering this on case management, so there was care coordination, there was social needs assistance, there was legal services provided, and obviously emergency services was part of that continuum, but we were now seeing ourselves being part of a much bigger initiative. This was focusing on mental health services. Again, to overcome stigma, you weren't necessarily putting people in one-to-one individual therapy. There were group sessions. There were opportunities to do mindfulness and coping, and as well as dealing with grief and bereavement. Like was mentioned earlier, it's not just the victim of violence. It is their partners. It is their families. It is their people around them. So there was an opportunity to really address their whole support structure. In terms of service flow, like we said, there was mutual referrals, so it wasn't just coming from healthcare providers. Law enforcement and victim services were making referrals, as were our community partners. Then we would do a needs assessment, and then through multiple avenues address the needs of the patients and clients, and then work on it in a longitudinal fashion. As I mentioned earlier, the community involvement I didn't actually quite mention it. The community symposium did lead to the formation of a community advisory board, which continues to inform the TRC. But in addition to that, we provide training for law enforcement and for other groups that want to work from an evidence-based place, as well as outreach to the community, providing summer programs for youth. And those kinds of services. In terms of next steps, sustainability is a big issue here, and the goal is to look for how to make this work with Medicaid funding and Medicaid waivers. So state-administered federal funds with a local match will be the way forward. The hope will be to directly bill Medicaid for these types of services as part of the healthcare provision for individual patients. And to really get this started, you do have to find where your local resources are. Like I said, like Dr. Thomas had mentioned, we started with a community foundation that had an interest in addressing this, and that was our funding that got us started. Then we found this state funding. But a lot of it has to do with working and listening to your CBOs. A lot of this work, if you look at who got funded, it's the CBOs that got a significant amount of the work, because we needed to resource them to scale up and provide these services. And you work iteratively. Like, we had some sense that there was much more need than the violence intervention program, but we could only get there by demonstrating these iterative successes. And it is now expanding across LA County. We were at the time the only TRC based out of a public hospital. That is no longer the case, and that is good news. So we would want to definitely give a shout out to all of our partners, both with the HVIP and the TRC. And we will end it there. We would like feedback, so we'll have time for questions now, but if you can scan the QR code, we would love to get feedback on this session. Thank you.
So as Kabir said, the forum is now. We wanted to have a lot of time, and hopefully we do. Yeah, almost 20 minutes or so. for conversation around community engaged research approaches or about the specific projects they mentioned. So the floor is yours. You guys can come up, ask from your seat or ask from the mic. I know this is being streamed, so I was told that you should try to come to the mic so people can hear you, but I don't want to force people.
Wow, thank you. That was mind-blowing. My kind of selfish question is about intersectionality. So I work in older people, and I realize I have a deficit kind of in the intersection between older people and racialized communities, and then add on to that mental health, right? You know, where certain communities, nobody has a logo. They don't have a community-based organization because, you know, part of their cultural foundation is that's not our problem, right? So I'm just, if you've got any thoughts about that, you know, like you're trying to reach out to a segment, you know, a specific setting, and, you know, the community-based organization don't exist or aren't evident. So I'd appreciate any of your thoughts about that.
Yeah, so I think that's a very, very important question. I'll mention that one of the things, I started a nonprofit organization to address a community that wasn't found within other community sectors, right? So I'm not suggesting you do that, but I am agreeing with you and validating the idea that there are certain populations that are not seen yet exist, right, within our healthcare system. And because that they exist but are not seen, they don't get certain resources. And until you lift that up, so like, you know, if you're, as I said, I think emergency medicine professionals should be public health interventionalists. We should think of that as a core aspect of our identity. Then perhaps one way to do that is through developing community-based organizations to serve those sorts of segmented populations or the intersectional populations that we're interested in, right? And I know that recently there's been a lot of organizational development around certain populations that weren't, again, existed, but were not seen very well, right? With respect to sexual and gender identity. So I think that that's one way to do it. The other thing is to, I'll say that so I work with Muslim populations, but a lot of them are African Americans, right? So within the very strong CBOs that are African American oriented, we could develop sub-working groups within the Muslim population of that, right? So we say, yeah, we're interested in that, but we're interested in the intersectionality between being black and being Muslim. And those larger CBOs were very interested in that as well. So we didn't start something else. We said, okay, well, we're going to have another working group that's focused on that intersectionality within our largest CBO. So that might be another way to approach that problem.
And then to just sort of piggyback a little bit on that, to working with some of the sort of more culturally focused groups, you will find that, I mean, most people, I mean, most communities do care about their elders, and there's usually initiatives already in play. Honestly, sometimes it's providing resources to help them actually do the work. So there is always this challenge to look outside and to see what's actually going on, which is not to say that you haven't, but for us, that was one of the things that we really had to force ourselves to do. Los Angeles is massive, so it wasn't that long before we found that there were people already doing good work. They just didn't have the resources, and so it was really us providing a partnership that was mutually beneficial.
Other queries?
Thank you for those excellent presentations. It was very illuminating. I was very interested regarding the CEDU program. How did the feedback and insights you got from people who use drugs affect how you kind of designed the program on the law enforcement side? And I ask only because it's a bit fraught, only because, you know, there is some literature that suggests that, you know, people who use drugs may be reluctant during overdoses to call 911 because they're afraid that law enforcement may respond. There's some data that, in fact, we shared today that police may be kind of less effective in terms of their frequency with which they administer naloxone or how effective it is than they do. And then lastly, you know, diversion programs often involve essentially mandating or quasi-mandating treatment that may not necessarily be evidence-based. So I'm curious to know how that dynamic works when you're ultimately trying to reduce harm by decreasing incarceration.
Great question. And I have to say, I'm just very humbled to be up on this stage since I'm very junior in this and very new to this. So that's going to be the lens that I give, is that I'm new to this and very excited to be learning from the people who use drugs who are part of our team. But I'm just trying to think of concrete ways in which that's already shaped the way that we've thought about the research design. And to be honest, like, our research development was kind of the chicken or the egg, because we had to get the funding before we could build the things. We kind of had a research question that was being iterated on at the same time that we were onboarding our co-investigators. So some concrete ways in which that developed over time, especially initially in the project, was that I'd say 3 individuals had lived in living experience of being incarcerated at some point in time, and many had frequent interactions with law enforcement in addition to other first responders in recent years. So their experience, recent experience, particularly with this kind of pinball effect within Washington State, in which there was this feeling that there was increasing antagonism with law enforcement and our state legislature on kind of criminalizing their behavior in which they're interacting with people who use drugs. So there's already this antagonism between these 2 communities. And the way our co-investigators really kind of, I think, set us, the research team, kind of back was to think, you know, should law enforcement even be part of this equation? Like, how can we actually rethink what a first response system is when someone's in possession of drugs? And how can we include other communities and interview other communities and interview other people who are in this intersection about what could be possible, instead of just saying law enforcement should be the point of contact for all individuals. So we ended up kind of broadening the net of people we interviewed to not just be law enforcement, but also other types of first responders, including BLS, paramedics, mobile crisis teams, mobile integrated health teams, and community paramedicine teams, in order to try to reimagine like what this could actually look like. But I think the trickle down of that in the way we kind of iterated on that with our interview guides, and the way that we kind of went out to the community, asked people about this, was to think about how we can really reimagine overdose response that didn't have to be this punitive way. And I think something that I came in to this project thinking was that everything we do in the emergency department could be translated out into the field. And I think it was really humbling to speak to people who lived in living experience to say, hey, you know, like, after overdose, maybe I don't want to be started on Suboxone. Maybe I just want like a warm blanket and someone to like listen to me. Like, that is just a very humbling when I want like things to happen out in the field. So I think, so it's just been really amazing to have people lived in living experience to really like kind of reimagine what could be possible, and also not to like pigeonhole us into like what our lens is as emergency physicianers from the School of Nursing or from law enforcement. I hope that answers your question.
Thank you for your
Yeah.
response. And you're doing an excellent job, easily holding your own with the other experts.
All right. Well, I think our time is up.
Oh,
One more
Dr.
question. Last
Porter.
question.
I just thought maybe. Thank you all for your presentations. I was hoping maybe you guys could just share at least like one small pearl or takeaway from when you start to go out and engage these groups. I think it can be really hard to kind of walk in and say, "Hey, I'm a doctor and I'm here to help." And a lot of these communities you guys noted have a really fraught history and relationship with the medical care industry. And so is there a certain, if there's one takeaway you guys had for folks that are either starting to do this research or want to do this research, when you come into a community group after you've identified somebody, what's one of your kind of tips and tricks to help engage?
I'll go first. So I think, I often give these talks, I think the most important thing is presence. So before you do any research on anything, I want to be part of that community. I want to be felt and seen as part of that community, right? So when we are teaching CBPR methods, or it's like you should spend 6 months going to community events, showing your face, right? And not being the expert. The problem is we go and I can tell you what you need to do. I have all this knowledge. I have that MD behind my, or whatever, DO, right? And that turns people off, right? So just being present there, I think, is the most important thing you can do. And present with an authenticity of, I'm just here to help, as you said, right? I'm just here to help if you want me to help, but I'm just here to listen. So that's what I suggest to my mentees. I almost spend 6 months being present at those events and those community forums, and being there not as the expert, but as the one who's listening and observing.
Yeah, I think another point is again, identifying the needs of that community. So if you have an idea for a project, you still have to, I think it would still be helpful to go to the community organization that you're interested in and ask them, is it something they're interested in? Do they have other needs that they'd like addressed as well? Is there some way you can expand your project to address their concerns and ensure that they're being kept updated and involved in every step of the development of your project?
And just to piggyback on that, I think something our group has really thought critically about is just to make sure that the project that we come up as a group has an ability to actually have impact and actually happen. Not that we've put bumpers on any of the projects that we've done, but we just wanted to be situated in a place where we know that the state legislature is thinking about this. So how can we use that timing to make sure that what we are doing actually has impact? And knowing that that's our collective goal is to have that policy impact, because that's what everyone on our team really feels and thinks is important. And to just be the vessel and support system to allow that to happen with our community members who are already working towards that goal.
The idea of compensation can't be overemphasized. You may feel like you're volunteering to do this work, but the community is definitely volunteering to do this work. They should be compensated. I'm not expecting you to pay them like an EM physician, but they should be compensated for their time. And they should be respected with what their outputs are and what you actually end up publishing. It's funny because the last time SAM was in New Orleans was 2016. We brought our community partners here to talk about their experiences, I believe, for shared decision making. Some good and bad stories about how they were treated in the emergency department, and they were co-authors on the outputs. They got to come and visit. Well, some of them had family in New Orleans. Like, it was a good experience, like kind of like how we have fun when we go on conferences. Bring your community partners along. But yeah, an idea of trust. The other thing is about transparency, like actually showing them what the products are, how they are represented in the work, goes a long way to make sure that they feel respected in what you do.
Thank you all for your patience with us. Have a good rest of the meeting.